algorithm. Okay, so if we want to start, we start with the introduction. Introduction, usually in terminology, we use ischemic heart disease, sometimes coronary heart disease, sometimes coronary artery disease. By more or less, they refer to the same condition where it is in general there is imbalance between the oxygen supply and what actually the oxygen demand. This interruption in the supply, or this interruption for this balance, can happen sometimes by stenosis, sometimes by narrowing of the vessels itself. Okay, and we hear all the time about the stenosis or the narrowing or the partial blockage of the artery, okay, caused by atherosclerosis. Lipid plaques come and accumulate and do partial occlusion of the artery. This partial occlusion will happen to embed the coronary blood flow, and sometimes will be gradual blocking until and unless will be significant narrowing of the artery that the clinical presentation will cause lead to partial blockage in the artery, and he can leave and everything is fine. And sometimes, in some cases, this clinical presentation, the symptomatic, will happen when the blockage has 70% or more. Okay, so it will vary the atherosclerotic plaques, but when to present and when to manifest clinically will be different from case to another. So the common clinical manifestation of the ischemic heart disease, as I mentioned, a chronic one, which is our interest this week, to focus on the chronic one, chronic stable angina, angina pectoris, or many other terminology, and the acute coronary syndrome, which refer to the acute cardiac attack, which we'll discuss inshallah next week. The chronic stable angina, or our interest today for the stable ischemic heart disease, same like chronic stable angina, both are the same. We are talking about chronic occurrence of chest discomfort, happen or most of the time will be caused by transient ischemia, with usually precipitated with exertion, exercise, vigorous condition that the patient is come across. So it is very important to understand it is a chronic condition. The ischemia here is transient, means if this ischemia is permanent, it is a cardiac attack. This is the issue. If this ischemia or this condition can happen at any time, this also will be a serious condition. If it happen only as a presentation or as maybe a consequence of vigorous exercise or physical exertion or any predictable pattern, this will be the chronic one. And apart from this one, which will not be focused that much, sometimes this narrowing cannot be just due to the atherosclerosis. Sometimes it's vasospasm. And vasospasm actually refer to another condition which relate or under also the umbrella of the stable ischemic heart disease, but this one, it is not caused by the atherosclerosis or the lipid accumulation inside the vessel. This one mainly caused by the coronary vasospasm. Coronary vasospasm, that brings metal angina. This is a different management from the stable ischemic heart disease, the traditional or the main type that we'll discuss today. Okay. So of course, maybe perhaps in our community or our families, or we have someone or maybe one of our relatives have this heart condition. So sometimes we get confused when it is maybe stable ischemic heart disease, when it is the other condition. So to understand to whom we refer to a stable ischemic heart disease individual, So those who had already a stable chest pain, that the dyspnea is suspected and predictable by time, and on the top of a very known exercise. This patient, for example, before doing some training, if he didn't get the nitrate, the vasodilator, and the sublingual one, he will have some chest pain. So this chest pain, he experienced the chest pain in the regular exercise. In this pattern, the chest pain will come. And that's why the treatment later will deal with this issue. And also another maybe category under the individual ischemic heart disease, we have those with previous episode of acute condition happen for one time, chronic for one time, has a cardiac attack, and after the cardiac attack pass and the patient discharge, then he happened to be stable for some time. Who are at present asymptomatic or have a stable condition or stable symptoms post revascularization. Okay. Just I'm not sure whether. Okay, we are recording already. Okay. So at present asymptomatic or have stable symptoms of the coronary artery disease post vascularization. So post cardiac attack or even the vascularization, and now they are stable. So in terms of epidemiology, of course, cardiovascular disease, and on top of this, the ischemic heart disease is one of the most leading cause of this worldwide. 17.5 million people each year worldwide died from this one. Of course, also the cardiovascular burden at the national level is very significant, has main cause of death in both gender, with the mortality maybe in the recent year have to come maybe a little bit decreasing with the era of the advanced prevention strategy and diagnostic procedure that can even in some cases diagnose this blockade or this ischemia before the cardiac attack happen. And this actually the aim of the care now is more toward this one. So now we done with the introduction and the epidemiology. Now we want just to highlight a little bit on the etiology and pathophysiology. We will not go in details, but a little bit. So etiology and pathophysiology, as we mentioned, most of the time we have this balance maintained between the demand and supply. The supply and demand have, of course, their main components. Here, the coronary blood flow, how the oxygen extraction, the availability, and the demand, of course, the heart rate, the cardiac contractility, the intermyocardial wall tension. This most of the time is maintained. In patients with stable ischemic heart disease, they are at risk of this balance to be disturbed. This disturbance can happen due to so many reasons. Can contribute to this one. Some of them can be just a modifiable risk factor that can affect certain component, and if we are properly managed this factor, a better response or a better control can be there. That's why we can say modifiable, or a non-modifiable risk factor that we cannot play with. Modifiable, of course, we have the smoking, the dyslipidemia, diabetes, hypertension, this very significant modifiable risk factor for ischemic heart disease, and all of these are well-established risk factor for ischemic heart disease. The non-modifiable risk factor is a bit different. We hear the aging process, normally in more than 45 in men and more than 55 in women. Normally they are at increased risk of ischemic heart disease compared to younger population. The gender, the men, as we mentioned, at younger age and at higher incidence rate will be exposed and at risk for ischemic heart disease, and we have a family history of all the cardiac issues. So if we want to maybe to understand actually why this risk factor can be linked to ischemic heart disease, we can see how they can affect the endothelial or have impact or contribution to cause endothelial dysfunction. Most of the factor that we highlighted as a modifiable risk factor, they by somehow they affect here because endothelial dysfunction, and that's how the smoking actually is relating or linked to the stable ischemic heart disease because endothelial dysfunction. So this normally we have this one antithrombotic, anti-inflammatory. Once the endothelial dysfunction happens, this substance produced, and the main action will be more prone to the inflammation, more prone to the thrombus to come, and many other problems in this cascade will happen. So in the pathophysiology, actually, what make it a bit different between the ischemic heart disease, the one we call this a chronic base or chronic nature, ischemia, and the ACS, the acute coronary syndrome, that we will discuss, inshallah, next week. So the etiology, I think it depends. Which one is predominant? It is predominant by the atherosclerosis, or the predominant here with the thrombus formation, the immediate thrombus formation. So the hallmark means the cardinal pathophysiological sign of the chronic stable angina, the stable condition that you have established atherosclerotic plaque in one or more condition, and that sometimes can happen to up to 50% of the coronary artery have atherosclerotic plaque established. Means the plaques are there, they are staying, and the body adapt without any significant clinical manifestation yet. The issue of the acute coronary syndrome, that inshallah next week, this atherosclerotic plaque, a rupture will happen, and the thrombus will come in, and the subsequent cascade of the thrombus formation will take place. And that's how this acute nature, and this will be very serious if this thrombus and this has not been managed immediately. And that's why later, inshallah, we'll discuss how significant the time to do the thrombolysis, and we find that thrombus will be determined in the outcome of the acute cardiac attack, inshallah. Okay, so you can see here what do mean by the chronic stable angina. When this lipid, the lipid core or the plaque is already there, is very stable. And you can see here what will happen in the acute coronary syndrome this next week. This staple will become ruptured, the platelet come, and the platelet aggregation start to take place, and later will be thrombus formation and complete blockage of the coronary artery in the acute cardiac attack. Okay, so this one I think is very important to understand between the two conditions. So clinical presentation, diagnosis, and risk assessment. So far we came to know a little bit of the introduction. Who should we call the stable ischemic heart disease? And etiology and pathophysiology, the cardinal maybe hallmarks here and there. Now we will discuss about the clinical presentation, diagnosis, risk assessment, prognosis, what happened in the clinical pathway for patients with chronic stable angina. So first of all, when we call stable angina, we define it as a clinical syndrome. The most important is a predictable chest discomfort. Predictable because it is mostly will be provoked by certain exertion or stress or some situation that the patient can predict. And we leave by rest or nitroglycerin. And that sometimes if the attack happens, that sublingual nitroglycerin should be just enough. And sometimes people, before doing exercise, just doing putting the subliminal nitroglycerin, so this predictive chest discomfort will be less likely to happen. Okay? The 5 components commonly used to characterize the symptoms, the cardinal receptor, which is the chest pain, would be the quality, how the pressure, the heaviness, the tightness, the squeezing of the chest pain, the location, most of the time will be the anterior chest area, will be radiating to the neck, the jaw, shoulder, and back. The duration, typically it will maybe last for several minutes. Provoking factors, which is very maybe characteristic for the stable ischemic heart disease. It must be provoked by something. In the cardiac attack, it happened with nothing. The patient is at rest and the cardiac attack will happen. This one, the stable ischemic heart disease, most of the time the pain should be provoked by exertion, provoked by emotional stress, provoked by so many other reasons. Relieving factor, there are well-defined relieving factor, as we mentioned, the sublingual nitroglycerin as an intervention, or just rest. Apart from this, when we call about the characteristics, it is good also to know that some individual can present with atypical symptoms. Atypical symptoms means just indigestion, gastric fullness, back pain, shortness of breath, that's all, okay? And this actually atypical is common among the women, elderly, and diabetic patients. And also diabetic patients who are elderly, relatively old, can also having maybe some other presentation apart from the classical chest pain symptoms. And at that time, and they can be called or classified under the silent ischemia. Silent ischemia means the ischemia is going on, but no chest pain. The Creatinine test of cardiac enzymes in chronic angina is normal. But in the cardiac attack, the myocardial infarction, MI, the myocardial infarction, of course, will be elevated, and the significance, inshallah, we'll discuss next week. The hemoglobin, all these parameters can just to assess the cardiovascular risk and help to establish differential diagnosis. Differential diagnosis when we suspect so many conditions. So this will help you to refine the suspicion list and do the final or the exact medical impression. So in the diagnosis in general for ischemic heart disease, you need to know the detailed history. As you mentioned, there are certain provokes and factors, so the detailed history is very important. The ECG will be of high importance to be done. And of course, the stress testing is also very significant because the stable coronary artery disease patient used to have this chest pain at consistent rate pressure, means at certain level in the consistent pattern, this pain will happen. Okay, abnormal responses during the stress testing, abnormal responses in terms of the heart rate, then the blood pressure, giving a signal there's a coronary artery disease here, and ischemia may be embedding is going on. Of course, now it is all about maybe the make best use of the catheterization or the angiography to identify the least common causes sometimes, which is the coronary artery spasm, the Prince-Metal angina that we highlighted earlier. So it is good just to know for our knowledge that so many cardiovascular society have maybe classified the severity of the presentation of the ischemic heart disease according to the limitation they imposed to a particular individual. So the severity of the pain you can see from class 1 to class 4. Start with just a rapid or prolonged exertion that provoke the angina, and the limitation is actually none. Here the problem can happen with walking, climbing a stair rapidly, and the limitation maybe can be slightly limitation. Here, the walking 1 or 2 blocks in the level, and he starts to experience the pain. And here, the limitation for the activity will be a marked limitation. Here, in the very severe form of the ischemic heart disease, we have inability to carry out any physical activity, and that's how the patient can experience overall discomfort in all the activity that she or he is performing. So how the prognosis, how the disease will progress with patient with stable ischemic heart disease who are not yet developed the cardiac attack or compared to this on cardiac attack. In stable ischemic heart disease outpatient, usually incident, the MI, the myocardial infarction, or the cardiac attack after the first year, the rate will be almost 0.8% as an annual, and most of the time is be predicted or provoked by cardiovascular risk factor, means poor control diabetes, poor control lipid profile, and active smoking. This will increase the risk of patient of ischemic heart disease to have a cardiac attack. And persistent angina, this the one we call a severe presentation that usually involve multi-level disease. So you can see here maybe the MI incidence is around 0.8. Here, on the other side, for the acute coronary syndrome, for patient with happen to have the cardiac attack, this one was maybe the risk of the combined endpoint for them to have another myocardial infarction or ischemic stroke or even cardiovascular death following or in a 1 year will be around 18.3 during the first day post their first MI. So it happened, for example, unfortunately have MI today, over the next year is still around maybe 20%, around 20% risk to have another attack or to have stroke or to have cardiovascular death. So you can figure out here how it is how it's serious, the difference or between the patient have a cardiac attack and patient on chronic condition. And also we can figure out how important for patient in stable ischemic heart disease to not to develop cardiac attack, not to amplify the risk of having the cardiovascular mortality as explained by the percentage here and there. Okay. Brother and sister, are you following me right now? Still surviving?
Yes, doctor.
Okay. So before we go to the treatment, what actually what makes the stable coronary artery disease management the adverse outcome to happen? Okay. So those patients most likely have a relatively poor prognosis when they have the stable coronary artery disease or stable ischemic heart disease. So those relatively old, those have before an MI, as we mentioned, those with symptoms and signs of coronary heart failure, of course, pattern of the maybe the occurrence of the angina, maybe it is recent, will be evaluated, is progressive, how it is responsive to the medical management that has been given. Written as atherosclerotic disease, we have another maybe problem with the peripheral vessels, cerebral stroke, aorta, presence of the cardiovascular risk factor, the well-established cardiovascular risk factor, and how they are all well managed. Of course, on top, the diabetes and metabolic syndrome. Coexisting medical condition diabetes and chronic kidney disease is very important, okay? And later, of course, the psychosocial factors, depression and poor social support, actually one of the major contributor to the adverse outcome, of course, to the stable coronary artery disease, sometimes by direct, sometimes by indirect impact. Okay, so here, what actually makes the prognosis poor and increase the risk of patient to have adverse outcome with the treatment. Okay, so now we have finished with the introduction, epidemiology. We have done with the etiology and pathophysiology. We have done with the clinical presentation, the diagnosis, what should be there, the risk assessment, the prognosis, and the adverse outcome. Okay. Now we will discuss about the treatment outcome and pharmacotherapy overview. So I think in general, we have to understand that as a desired outcome, the desired outcome in patients with stable ischemic heart disease, in the first place, we want to prevent them from having the acute coronary syndrome, from having the cardiac attack. Of course, this the our most important outcome to be achieved. Alleviate acute symptoms of myocardial ischemia, of course. The symptomatic management of the ischemia is very important. Prevent the recurrent symptoms of myocardial ischemia, also very important, because this one impacts the quality of life, how the patient can survive with the condition, which is very relevant and important. Prevent progression of the disease. As we mentioned, the disease progression and prognosis can be modulated by so many factors. So one of the desired outcome to investigate what are the factors that may contribute to the adverse outcome in this case, and how we can intervene with this one to prevent the disease progression. Reduce complication of ischemic heart disease, of course. Avoid or minimize the adverse treatment effects or the adverse treatment side effects that can or maybe happen due to the treatment. So, general treatment approach. What actually we have here in the angina symptoms. So after you have the angina symptoms, of course, as we mentioned and as we highlighted, we have a diagnostic workup will be there. History, ECG, stress testing, coronary angiogram, so many will be there. We have also a list of risk factors that will be identified in the given case. We have a list of the modifiable risk factor, right? So we have modifiable risk factor that we can play with if we want to modify the risk of the patient. Means decreasing risk. Modify here, of course, we want to decrease the patient risk. Of course, after modifying the risk, up till now we modifying the risk, but we didn't intervene with the disease, right? So the next point or the next block will have the medication that can prevent the cardiovascular events from happening. This medication usually given to decrease patient risk to have the cardiac attack, And then after this medication has been given, we have a certain medication just to symptomatically treat the patient ischemia. The patient ischemia means the ischemic symptom, we can treat the symptoms, but will not affect the cardiac attack from happening. It will be just as a symptomatic treatment. So again, we have after having the symptoms during the diagnostic workup, we have 3 main blocks in the management of a stable ischemic heart disease. The first block is focusing on modifying the risk or decreasing the risk by playing with the risk factor. The second is targeting how we can prevent the cardiovascular events from happening, or the next cardiac attack from happening. And the third block or the third group is the anti-anginal therapy or anti-ischemic therapy. Anti-ischemic therapy most of the time will be just a symptomatic treatment, so the patient quality of life can be maintained. Okay, so as we mentioned, we have this treatment for the prevention of primary and secondary events, we have this risk factor modification of antiplatelet therapy, and this what we call vasculoprotective therapy, including whatever, if the patient for example, stop smoking, so we can interrupt the endothelial dysfunction, so we can recover this endothelial dysfunction. So we help the patient to decrease the risk of the cardiovascular events. If we give this medication, the risk factor modification, when we talk maybe dyslipidemia, when properly manage the hypertension, when properly manage diabetes, all this contributing to modifying or decreasing the patient risk of having this incidence or the future cardiovascular events. Of course, also we have the antiplatelet therapy. The aspirin, the antiplatelet therapy is very important group of medication under the vasculoprotective, the one for reducing risk of future events. It's very important for you, brothers and sisters, to understand what actually every medication is used for. For example, when you talk about antiplatelet, so antiplatelet therapy is one of the vasculoprotective therapy that aims to reduce the risk of the future cardiovascular events. It's very important. What about the other group of the pharmacotherapy that can be given? The one what we call anti-anginal or anti-ischemic pharmacotherapy, and this, as I mentioned, it is most of the time for symptomatic treatment, for relieving the symptoms, so the patient quality of life can be improved and the patient can happen to live with the condition without major limitation or restriction to his or her daily activity. In this medication, we have a group, maybe beta blocker, nitrates, calcium channel blocker. So many group of medication can be there, and you have other medication also under this class, which is relatively less commonly covered and highlighted by the evidence, like avapradine, trimidazidine, nicorandil, and ronaldine. Okay, and of course, later, apart from the pharmacotherapy, you have this maybe myocardial revascularization that sometimes can be one of the measures, as we will highlight later. So, in general, as I mentioned, in terms of medication, we have medication that targeting reducing the future cardiovascular event, and medication targeting the symptom treatment. Okay, so usually which one to be offered and how we can proceed with this one, it depends on the risk stratification. Risk stratification means you assess the risk of this individual in terms of the risk of annual mortality. Low risk individual means annual mortality less than 1, intermediate risk individual 1 to 3, high risk individual 3 and more. Okay. So for those low risk individual can manage only or can manage just by risk factor reduction and anti-anginal medication, okay, as necessary. No intervention here required. Vascularization or myocardial vascularization is not that recommended at this level. For the intermediate risk individual, can risk reduction strategy that we highlight details plus or minus the anti-anginal therapy, and at this category, in this group, you can consider the invasive coronary angiogram or revascularization as required. For high-risk individual, beside all this, the invasive coronary angiography will be recommended. Okay, so choice based on the risk stratification. Okay, I think I have done for the 40 minutes. If you want me to stop here, I will stop here to maintain the screen time at 40 minutes, and we can continue tomorrow. What do you think? I understand that maybe all the students need only 40 minutes. So if you want to just to stop here, is okay. I have delivered, I think, the how many? Okay, brother and sister, you want to continue or stop here? I will continue a little bit if anyone, but this optional. So anyone want to? Okay, sister, anyone want to say something?
Doctor, I think you may continue.
Okay, I will continue, but you have the choice if you want to stay. More than welcome. If you want to stick to the 40 minutes, also up to you. No problem. Okay. No attendance from this point onward will be taken. Okay. So as we come together to the point treatment outcome. So we have behavior modification. Behavior modification, sometimes we call lifestyle modification. Most of the time refer to the same issue. So when we call about the lifestyle modification, we want to make sure that the patient is well versed and well educated about the disease condition, the diet, and the impact of the diet on the cardiovascular event. There is some data on the Mediterranean diet. Physical activity and physical exercise in the range of at least 150 minutes is of course a general recommendation for a cardiac health, smoking cessation, and weight management. This overall the behavioral modification therapy for the cardiovascular health. Here is a bit of the summary of the cardiovascular prevention recommendation, okay, and what we are aiming to. So in terms of each and every point, what we are aiming to decrease and interfere with the patient risk for the cardiovascular disease. Here the individual of course component and the individual recommendation for managing blood pressure, lipid management, diabetes, and this actually can be well discussed, of course, under hypertension and dyslipidemia. Later, inshallah, we'll discuss in details about this one. So the behavior modification therapy, it is not that much. It is a general recommendation about lifestyle modification that can be or should be adopted as much as possible with all the cardiac patients as they can afford and can maintain. Okay, so next we have under the treatment what we call the risk factor modification. Risk factor modification, we come here to the treatment. You remember the treatment that we call vasculoprotective pharmacotherapy. The one aims to prevent the cardiovascular events, from happening. For this risk factor modification, we have so many agents. Of course, if we say that atherosclerosis and lipid accumulation is the main pathophysiology, maybe trigger in the development of the ischemia. So we have to think about the lipid modifying agents, and sometimes we call lipid lowering therapy. This will be of utmost importance in any patient with ischemia, chronic or acute. Later on, we'll discuss in details about this one. Of course, when we talk about lipid modifying agent, we have statins. The statin therapy has been shown by very well-established evidence that they are able to improve prognosis. Improve prognosis means they can modulate the patient risk to have the future cardiovascular event. They test between the statin receiver and the statin non-user, and they have a significant lower cardiovascular event in patient have or on using a statin. This is very important. And we'll discuss, of course, in details in the hyperlipidemia about this. And the more intensive low density lipoprotein cholesterol lowering was associated with greater reduction. And this actually one of the concepts in using statin therapy, what we call the lower the better. The lower the better means as low as you go lower as much as possible with the LDL level, the risk also will decrease. The incidence of cardiovascular mortality will decrease. And this actually it is not uniform with all the medication, but it is unique in the statin or lipid lowering therapy evidence. Also, it has demonstrated what we call dose-dependent reduction in the cardiovascular disease with the percentage of lowering of the LDL C level. The greater reduction means as much as you can decrease or reduce the low density lipoprotein, the harmful cholesterol more, the greater you will be able to reduce the cardiovascular risk. Okay. And the levels, in general, levels in patients with cardiovascular disease, it has been agreed by most of the guidelines that levels less than 1.8 will be associated with less progression for the atherosclerotic plaques. Means this atherosclerotic plaques will not be progress into future bigger and unstable plaques that later will make the thrombosis and make the cardiac attack. So this actually was observed very obviously in patients have LDL cholesterol level less than 1.8, and this actually happened or get to differentiate actually the target for the LDL-C in patient with cardiovascular disease and in patient with no cardiovascular disease. No cardiovascular disease means primary prevention. So those with primary prevention, 2.6 is okay. But those with cardiovascular disease, the impact or the goal for the LDL cholesterol should be at 1.8 or below. Okay. What else we have in the category of the medication that can decrease the risk and prevent the future risk of the cardiovascular event? Of course, we have the ACE inhibitor. ACE inhibitor, I think maybe perhaps you have been talk about ACE inhibitors so many times in hypertension with Dr. Eid, and also I think in heart failure also. So ACE inhibitor have very many clinical benefits for secondary cardiovascular prevention, especially in patients is already have hypertension, and those have already have a prior episode of cardiovascular attack, means MI happened before, and the left ventricular ejection fraction is 40. In those category, ACE inhibitor is very important medication to be there for the cardiovascular. That's why maybe a routine use means you offer ACE inhibitor for patient has no hypertension, patient is normal left ventricular function, is not recommended. So it is very important to understand when and whom will get the benefit of this medication. Okay, so as we mentioned, hypertension, post-MI, and left ventricular ejection fraction. But to be offered for anyone, it is not that the case, and not the recommendation actually by the guidelines. So in patients with stable coronary artery disease in general and reduced left ventricular ejection fraction, usually they can have a benefit and survival benefit from this medication. I think this in details should be or have been discussed already with heart failure last year with me in the introduction, and I think also have been discussed with Dr. Eid this semester in the pharmacotherapy for heart failure. So I will not go in details again for this one. So what else, brothers and sisters? So now we are still in what risk factor modification. We have one, the lipid-lowering therapy or lipid-modifying agents. Second, the ACE inhibitor. Third, the antiplatelet therapy. The antiplatelet therapy is one of the most important therapy in patients with ischemia in general, and many evidence is there that the aspirin actually can reduce the risk of non-fatal myocardial infarction, the stroke, and the vascular death up to 22%. 22% as an outcome in patients with stable coronary artery disease. Aspirin monotherapy in doses range from 75 to 150 remains as initial agent of choice, because under antiplatelet, as you may have maybe exposed in maybe the body system courses, you have so many antiplatelet, the aspirin, clopidogrel, prasugrel, ticagrelor, so many agents. So it's still aspirin is the initial agent of choice that should be tried first, and alternative to be considered if aspirin, if the patient have a problem to tolerate aspirin. Alternative can be, of course, clopidogrel, the teclopidine, although teclopidine is not that maybe well supported by evidence and have actually some hematological adverse events that is there, and that's why it is not a preferred option actually in practice. Triclosan, it is not that significant compared to the aspirin in terms of the impact on the secondary prevention of stroke and MI. So in what we can just highlight as a point regarding the aspirin, following even the ACS that will be discussed later, the risk of recurrent cardiac event, you remember when we talk about the prognosis, is still around 20% risk in the next year for the patient have recurrent thrombosis, recurrent stenosis, or even de novo lesions, mean lesions to develop in the pathway that we were not found before. So in this case, in ACS, this is very important. In ACS, we can hear about dual antiplatelet therapy, and this we'll discuss, inshallah, in details next week. So dual antiplatelet therapy. So antiplatelet therapy in general, for our understanding, for stable ischemic heart disease, antiplatelet is recommended. And in this occasion and this indication, one antiplatelet, which is aspirin, if tolerated, will be enough. When to use dual antiplatelet therapy, this one will be dependent on whether the patient have ACS or not. If ACS, and to decrease the very high risk of developing recurrent cardiovascular events, those patients with ACS can have dual antiplatelet therapy, usually aspirin, clopidogrel, for example, for the following 12 months, the 1 year, post the ACS, okay? And the use of the dual antiplatelet therapy. So some of you may ask, okay, after 12 months, what will happen? Just stop or just go back to the monotherapy? So the use of the dual antiplatelet therapy beyond 1 year in these who have maybe received the PCI. The PCI referred to percutaneous coronary intervention. Percutaneous coronary intervention, one on the procedure, and stenting has to be individualized. There is no general recommendation to recommend continuing the dual antiplatelet therapy in patients with maybe this ACS exceeding 1 year post the ACS or exceeding 1 year post the cardiac attack or the acute coronary stroke. So to make it short, for the platelet, you have a recommendation of using antiplatelet as a monotherapy, except for patients with ACS. They have to be maintained on at least 12 months. After the 12 months, just reassessment will happen for the patient risk of getting recurrent attack and the patient risk of develop bleeding. And the weighing the benefit and risk in this scenario will judge and will give a recommendation to continue beyond the 1 year or not to continue. Okay? patient with high bleeding risk, usually the dual antiplatelet therapy even can become shorter than 12 months, high bleeding risk. Okay? This overall recommendation of using the dosing and recommendation for antiplatelet therapy, you can see here maybe stable ischemic heart disease treated the PCI, bare metal stent, PCI, bare metal stent, the stent and the procedure. This actually from the American Heart Association, the American College of Clinical Pharmacy source. So this just a recommendation. The doses can be different according to the local setting a little bit. Okay, but you can see here what we have as initial dose, what you have as subsequent dose, because this usually initial will be just a loading dose. In a subsequent dose means a maintenance, and how long to be given. You can see here most of the time the aspirin in patients with stable ischemic heart disease will giving indefinitely. One of the main medication, as we mentioned, to reduce the risk of developing the future events. And the other group, the clopidogrel and ticagrelor and whatever the agent in this group will be here recommended, maybe perhaps 1 month, perhaps 6 months. It is not that recommended to be there. In general, for stable coronary artery disease, unless indicated as has been written here, clopidogrel for 1 month can be considered if the patient has low risk of bleeding can continue. Reasonable to discontinue clopidogrel after 3 months if patient has high risk of bleeding. That's why sometimes even not continue to 1 year, after the ACS. Okay. So here I think the summary recommendation, you can see here the aspirin in the first place. This one can be added and the duration can be discussed according to the bleeding risk and according to the patient individual risk of having a future cardiovascular events. You can see here this is the one from the local guidelines. You can see here the use of anticoagulant in patients with stable coronary artery disease can be also discussed according to the individual indication. Okay, I think that's all for today, and perhaps tomorrow, inshallah, we will start by the antiplatelet therapy. Of course, if anyone missed it, you can start with antiplatelet therapy and continue, inshallah, with the rest of the lecture. I think all of you have the notes, the slides, so you can have maybe have a look and prepare if any questions for tomorrow. Inshallah, we'll try, inshallah, to accommodate. And I think also later we will have a tutorial that I prepare some cases for you that we can discuss in details. Okay. Any questions? Any points I want to highlight before we end our session? Brother, sister, are you still here? Still here. Okay, alhamdulillah. So okay, if no more points, if no more questions for the time being, we can end our session by tasbih, kafara, and salat, and see you, inshallah, tomorrow 2 times, the PN and the second part of this stable ischemic heart disease, inshallah. Okay, thank you so much, and we can end our session. Subhan. Question, Ken?
No, thank you.
Oh. Okay. Okay.
If we have any questions, we will post in the group.
Okay, please, yeah. You can make full use of the teams if you want channels to be created, or you want to proceed any questions and under the lecture itself, we can go for it, inshallah, and we'll try to respond as much as I can, inshallah. Okay. Thank you so much. Thank you so much. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت نستغفرك ونتوب إليك. بسم الله الرحمن الرحيم. إن الإنسان خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالصبر. سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين. السلام عليكم.
Waalaikumsalam. Thank you, Doctor.
Thank you, Doctor.
Thank you so much.